Immense pleasure to welcome you all for this second webinar of FertilogiX webinar series. It's an collaborative academic initiative by MPSR and Universal NutriScience. Actually, a heartfelt thanks to Dr. Archana Basir Madam and MPSR and Dr. Asha Bakshi, and especially Kerala ISAR chapter for their constant support and enthusiasm in making this event possible. We are genuinely grateful for your commitment toward the academic excellence, right? So at this moment, I'll like to take this opportunity to say a few words about the UNS. At UNS, we take the pride for being one of India's fastest growing nutraceutical company. It's our mission to support the medical community, not just with a high quality product, but also valuable scientific initiatives like the FertilogiX. And this is a very special for us as we are celebrating 25 years of OQ 300. It is India's first and most trusted coenzyme Q10 brand. We also celebrating silver jubilee moment for this brand, whereas medical fraternity always stood behind it. Our another brand called Primoza continues to be a number one brand in APOs, that is aging primrose market. And our recent blockbusters like UNSD3, that is ultra nano solution for vitamin D3, has given a great success and remarkably achieved success in shorter period of time. So thanks for immense support from all doctors who are there at All India. At UNS, we are truly believe that knowledge sharing and is a key to better health, and FertilogiX is one of the steps that in our commitment to the cause. So once again, thank you so much for being with us. So with that, I warmly hand over this session to Dr. Shruti to take this forward. Right? So Shruti, over to you. Thank you.
Thank you, sir. So good evening, everyone. My name is Dr. Shruti Patwar. I'm from the Medical Affairs team of Universal NutriScience, and I would like to extend a warm welcome to all the esteemed faculties as well as all the doctors joining us online from different parts of the country. To the FertilogiX, this is the second one in the series, and today's theme is Mission Implant Possible. And all of this wouldn't have been possible without coordinators and as the program director, Dr. Archana Basir ma'am, who's also the chairperson of MPSR, and also wouldn't have been possible without the continuous support and guidance by Dr. Kalyani ma'am and Dr. Rudri ma'am. So Dr. Kalyani ma'am is the clinical director and senior consultant of reproductive medicine at Nova IVF, both Indore and Ratlam. She has over 17 years of experience and specializes in recurrent implantation failure cases as well as poor responders and low ovarian reserve patients. She has performed over 6,000 plus oocyte retrievals and embryo transfers. She also has a lot of awards and recognitions to her name, including both national and state level honors. She has received awards like IFS Subhash Mukhopadhyay Award, Isat Ronacharya Award, Youth Icon Award. She's also affiliated with some renowned organizations like FOXY, MPIAGE, and also contributed to the book chapter review journal and the editor for SRM journal. Dr. Rudri ma'am also has a lot of awards and recognitions to her name. She has also done a fellowship in reproductive medicine in vaginal reconstructive surgeries and a diploma in cosmetic gynecology. She was the university topper in MS and has bagged over 8 gold medals as well during her MBBS. She has won an award for paper presentation in AMPOGS 2020. She has presented a paper as well as posters in various national conferences, and her paper has also been recognized in various index journals. She has been a faculty in various national and international conferences and was an organizing committee member for Fertivision, NAOG-Con, and AICOG as well. She's also a recipient of IFS Achievers Award, IFS Appreciation Award, and also has written a book in or practical ART. Apart from it, she's also affiliated with various organizations like FOXY, ISHRE, ASRM, SR, IFS, and so on. So with this, I would like to hand over it to Dr. Rudri ma'am.
Thank you, Shruti. Thank you so much for your kind words of introduction. Let me proceed ahead. First of all, I would like to extend my heartfelt welcome to all the delegates who joined us today and all the faculties who accepted our invitation and took out their time from their busy schedules. It's indeed my honor to host this most prestigious webinar featuring esteemed faculties and experts with us from the southernmost part of India today. So, without much ado, let's begin our program by invoking divine blessings. May I request from our technical team the lamp lightning video, please?
Yeah.
या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदा जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम् Thank you so much, Shruti. Going forward, I would like to request to have the CV of Dr. Archana Basir, ma'am, please. So, I extend my heartfelt welcome to Dr. Archana Basir, ma'am, and would like to tell our delegates that this FertilogiX webinar series is the brainchild of Dr. Archana Basir, ma'am herself. Ma'am needs no introduction. She is chairperson of MP chapter of ISAR and a senior ART consultant. May I have the CV? Yes, yes. And senior ART consultant and OBGY practitioner of Indore. She is director at Akash Hospital, Indore, and she has been vice president of FOXY 2020. She has been an organizing secretary of AICAT 2021 Indore, and she has been holding so many various prestigious posts. To her credit, there are multiple publications and awards. I request Dr. Archana Basir, ma'am, to introduce and welcome our chief guest, Dr. Bakshi, ma'am, and Dr. Suchitra, ma'am, and take the session further.
Thank you, Rudri, for kind introduction. Good evening to everyone. I welcome you all on this FertilogiX series of MPSR. It is basically we wanted to connect with all of you, like from all over the country, and I'm really happy to see that all of you have joined. I have chief guest and guest of honor, chief guest Dr. Asha Bakshi. I'm going to give her a formal introduction. Before I go to her formal introduction about her awards and positions, she is a great friend. She is a MP. I mean, she's an All India ISAR secretary and too many first to her credits. Now we have Dr. Suchitra. She is the president of All Kerala Ops and Gynae Society. We have Dr. Faisal Lewis, Dr. Kunju Moidin, Dr. Parshuram, and we have all the panelists with us, Dr. Raj Mohan, my dear friend, Dr. Mumtaz, Dr. Remya Binesh, Dr. Abhi Koshi, Ekika, Dr. Shisha, Dr. Sheila Balakrishnan, whom I have connected after many years. She's from Trivandrum, Dr. Mahesh, Dr. Madhu, Dr. Dipti. So, I mean, all of you have taken time out to connect with us on this FertilogiX. And this idea is just to, take different topics in each webinar. And this time we have taken, which is a very tough topic, like making the implantation possible, mission possible. So let me now formally introduce Dr. Asha Bakshi. So can I have Dr. Asha Bakshi's CV here? Yeah, so Dr. Asha Bakshi, she is member of Executive Committee, AICC RCOG West Zone, founder chairperson, MP IAG and MP ISAR, chairperson of Foxy Infertility Committee. She's past president IOGS, vice president 2022 West Zone, Foxy from West Zone. And to her credit goes first ICSI, TISA ICSI, and Micro TC ICSI babies of MP. She's recipient of Dr. Kumud Tavaskar Award 2008-2009, and she has organized several conferences. As a matter of fact, I have been with her in many conferences we have organized together. She organized ISAR Endogen in 2019, organizing chairperson AICOG 2022 Indore, and she has organized chairperson of New Age OGCon 2023 at Indore. So Dr. Bakshi is a well-known name in the field of infertility and in the Foxy, and she's a great friend and she's a very good academician and a very good human, nice human being. Over to you, Dr. Bakshi, to just give us the words of wisdom, advice, and your inputs on this.
Thank you, Archana, for inviting me. And it's always a pleasure because actually I cannot imagine Archana inviting me because I'm always with her. Wherever we go, when they meet us, then they ask, where is Archana, where is Kavita? So we have been known as 3Bs and everywhere we are together. So Archana, I'm with you all the time. You don't have to really invite me. So, and I'm very glad that you are really, you have got this, of course, today's theme is very good, implantation possible, but your another mission is also important, that you are going to go for election as President Foxy, which is a very, very big thing and really requires a lot of effort. And I think you have all the qualities, and just you have to really work hard and go to all places and meet people and show that you have all the qualities. And I'm totally confident in, I have total presentation that you have selected is very, very good, because that's where we all get upset. Everything is good and we feel that yes, she should conceive. And when the result comes, we really feel so upset. And then we feel what went wrong. And I'm sure today all these mysteries will be solved. And another good idea is taking Kunnur Society with you. And now I'm attached to Kunnur Society because I have been to Kunnur and I've witnessed how enthusiastic these people are. They are very good academically as well as very good even in cultural program. In the evening, the last year I had attended that program, and the cultural program was also very excellent. So congratulations, Dr. Suchitra. I was very impressed by your society. And another thing I liked is you are near Gadwal, so I could buy lots of saris there as well. And today your topics are very good, and we have selected Dr. Fesiluis, Dr. Parsuram. They are all going to do justice to the topics. And another thing is I can see Kalyani and Rudri maturing up. And I can see that they are also going to be in National ISAR soon. And all the best to both of them, and keep doing the good work. So Archana, best wishes to you always.
Thank you, Ashadi. Thank you so much for your kind words, your encouragement, and your support always with me. As you said, 3 parts of any conference is academics, maybe there is some spirituality, but most important is shopping for women. So that is very, very important. So thank you very much. Stay with us for some time. And over to Dr. Suchitra. Sudhir, can I have the CV of Dr. Suchitra? Dr. Suchitra is a senior gynecologist at Aishwarya Multispeciality Hospital, Kunnur, an alumni of Calicut Government Medical College. She is practicing gynecologist since 1987 and medical director of breast cancer brigades in MCCS. She has held several positions: president of Kannur Obsgyne Society, adolescent chairperson, vice president of KFOG, and editor of KFOG Journal, and now she's president of KFOG. So she has worked in the Lions International Club as well, She has many awards: Best State Vima Chairperson Award and winner of Lalita Memorial Award and winner of Lions International Gold Medal and Gynec Awareness of Adolescent Girls. So we are really looking forward to have your blessings and any inputs, Dr. Suchitra, on this. So please, dais is yours.
Thank you, Dr. Archana. I'm really delighted to be here amongst this galaxy of infertility specialists. Actually, I'm just a gynecologist, ordinary gynecologist, but I'm so happy to be here amongst all of you. And I was really enchanted by the title, that is Mission Implant Possible. It's something like a James Bond movie. Mission Implant Impossible. You have made the impossible possible. That's what you're doing. And recurrent implantation failure, we know, is a very heartbreaking event, not only for the patient, but also for the doctors who are treating her. So I am really happy to be part of this. And I'm so happy that Dr. Archana Besser is flying to greater heights in the near future. And Dr. Asha Bakshi, she was so kind enough to remember our Kannur Society. Of course, we have a lot of cultural activities in our place. And here we have very, outstanding people. That Kalyani Srimali, madam, was calling me so many times. And also the Shruti Patwal. She was repeatedly calling and reminding me of this program. And of course, the chairpersons, Dr. Chandrasekhar, Dr. Mumtaz, Dr. Remya, all these are part of our Kerala Federation of Obstetrics and Gynecology. And two brilliant speakers today. We are looking forward to Dr. Archana Besser's talk on decoding the implantation program. And also Dr. Facey Lewis, who's going to be the president next year of KFOG, and the moderators, the very vibrant immediate past president of KFOG, Dr. Kunju and the very well-known infertility specialist, Dr. Parshuram Gopinath, and a wonderful panel of people who are members who are participating in this. And of these, my dear friend Sheila Balakrishnan is there. I'm so happy to see her on the panel. And Dr. Archana, I wish you all the best. And thank you so much for including me in this. And I hope we are looking forward to a great panel. And Dr. Deepthi is also here. She was here from the beginning. So thank you, all of you, and wish you all the best. God bless and good luck.
Thank you. Thank you, Dr. Suchitra, for your kind words and encouragement and, for being with us this evening, sparing time for us. So we are really, really blessed to have you on our program. And we now, I think, without much further ado, get on with the scientific program. So over to you, Dr. Rudri, to start with the scientific program. So Dr. Suchitra, stay with us. We'll make this thing possible, implantation possible.
Thank you so much, ma'am. And thank you so much, our chief guest, Suchitra ma'am and Dr. Bakshi ma'am, for your kind words. And especially, I would like to say that Dr. Bakshi ma'am is my godmother, and whatever I have learned, that is from Dr. Asha Bakshi ma'am herself. So extremely thankful to you, ma'am, for joining us today. Now going forward, I would like to brief my delegates that we will have 3 sessions today. The first session will be taken by Dr. Archana Besser ma'am herself. The topic is decoding implantation failure. The next session would be taken by Dr. Facey sir, which would be thin endometrium and overlook barrier in RIM panel. And thirdly, we will have the brainstorming panel discussion with us. And the moderation will be done by Dr. Kunji Moideen and Dr. Parshuram Gopinath sir, with our esteemed panelists joining us. So first of all, I would request our chairpersons to join us today. For that, I would like to invite Dr. Chandrasekhar Nayak sir as our esteemed chairperson. Dr. Chandrasekhar Nayak sir is a senior consultant of ART at St. Joseph Hospital, Dharmagiri, Kothamangalam, and a president of Malandu OBGY Society. Heartiest welcome to you, sir. Next, we will have introduction. Yes, sir. Next, we will have Dr. Remya ma'am with us as our next esteemed chairperson. Ma'am is a senior ART consultant and she is practicing at Esther MIMS Hospital, Kottakkal, Kerala. Ma'am has been awarded with so many awards since her career, and she is a chairperson for the KFOG Oncology Committee, and she has been an invited speaker at various state and national conferences. Heartiest welcome to you, ma'am.
Thank you for my opportunity. Thank you.
Ma'am is professor and unit head at Department of OBGY MES Medical College, Perinthalama, Kerala. And ma'am has been awarded so many prestigious awards, naming Kalyani Kutti Amma Memorial Gold Medal Award for the best paper. And she's the chairperson of Oncology Committee KFOG, secretary Perinthalamana OBGY Society, and author of USG for Beginners and CBME textbook. Heartiest welcome to you, ma'am.
Thank you, Shruti. Thank you, Dr. Rudri.
Now I request Dr. Thank you, ma'am. Now I request Dr. Archana Basir, ma'am, to take the session further with her lecture.
Good afternoon, good evening, everyone. Can I be allowed to share my slides? Hi, Mumtaz. Good to see you. And
Hi,
Dr.
hi,
Renia
ma'am.
and Dr. Naik.
Ma'am, you can check now.
बोलिए संगीता तुम बात मेरे को बोलना मैडम जस्ट लेक्चर स्टार्ट करो हाँ ले ले तुम सारा सामान ले लो सब ले लो Hi, can I start my talk?
Yes, ma'am,
Hello.
you can. Your slides are visible.
Dr. Naik, may I have permission to start?
Yes, ma'am, you go on.
I know this, Kalyani has really given this title. She is very fond of kind of Mission Impossible things title. So she has given me a very difficult task, decoding implantation failure. We, as Dr. Bakshi has said, that we really all get puzzled whenever there is an implantation failure. We all are really, working, and where we get good embryos, nice, your women, young women, good endometrium, good blastocyst, and patient fails. So my roadmap of my talk, we're just going to take you briefly through definitions, reasons of implantation failure, investigations, and how to prepare for the next cycle. So if we take about the implantation failure and recurrent implantation failure, implantation is the first step of crosstalk between embryo and endometrium, which is key point for successful pregnancy. Process includes apposition, adhesion, and invasion. Successful implantation identified by intrauterine gestational sac on ultrasonography. Now, implantation failures occurs during attachment and migration process with a negative urine or blood test for HCG or failure to form intrauterine gestational sac with positive HCG. What is recurrent implantation failure? Characterized by lack of implantation after transfer of several embryos. When more than 2 embryos transfers fail to result in a pregnancy, the term RIF is often used, and it is disturbing. And 10% of couples who are undergoing IVF and embryo transfer experience recurrent implantation failure. Now, what we already know about recurrent implantation failure, that it has no clear definition. Hence, term recurrent implantation failure is currently used somewhat haphazardly based on clinicians' judgment. Key factors to be considered while establishing the definition of RIF are the number of embryos transferred, unsuccessful IVF ET cycles, embryo quality, whether it was fresh or frozen embryos, maternal age, and which are the disputed points. So increase in cumulative live birth rate with more IVF ET cycles shows a progressive decline. So a blind increase in IVF ET cycles may not lead to successful pregnancy. So hence, if you have a implantation failure, you really need to look into that, what went wrong and can it be corrected rather than going for another cycle. Now, what are the challenges which you face? Multiple investigations and interventions are offered. If your patient fails implantation or fails in IVF, you start investigating and intervening. It is often applied without biological rationale, and no widely acceptable definition or standard protocol for recurrent implantation failure diagnosis and treatment is available as of date. Unequivocal evidence of benefit is lacking, and progress hampered by lack of widely accepted definitions. So, Coughlin et al. Definition of RIF. This is definition which is a little acceptable. It is based on the challenges and factors to be considered while defining recurrent implantation failure. The widely accepted definition of RIF is failure to achieve a clinical pregnancy after the transfer of at least 4 good quality embryos in a minimum of 3 fresh or frozen cycle in a woman under 40 years of age. Now, there are several problems arise with such a fixed and precise definition of RIF. Firstly, it does not take into account variables that affect individual prognosis for successful treatment based on both patient and ART clinic related factors. Secondly, concept of recurrent implantation failure as a syndrome or disease that can be diagnosed and treated is open to challenge. So ASHRI working group on RIF recognized that there is a need to look afresh at how RIF should be identified, defined, and managed. So ASHRI, if you look at the ASHRI 2023 guideline defining recurrent implantation failure in ART, population to individual, to address ambiguities in definition to date, following description of RIF is recommended. RIF describes the scenario in which transfer of embryos considered to be viable has failed to result in a positive pregnancy test sufficiently often in a specific patient to warrant consideration for further investigation or interventions. And key is need to identify how many embryos or embryo transfers would be expected to be necessary in a specific patient to provide an acceptable cumulative chance of successful implantation. So these two factors are essential for the individual approach for RIF model used to estimate the chance of implantation pregnancy and level at which the threshold to act is set. So this is a model used to estimate the chance of implantation. Likelihood of successful implantation after ART is determined by multitude of factors, including but not limited to: number one, female related factors, which is age, hormone levels, endometrial and uterine status; embryo related factors, cleavage speed, euploidy, previous implantations; and male factors, genetic disorders; and external factors are lab performance, clinic policies, and legal restriction. Ideally, a prediction model, including all these factors, should be used to provide estimate of cumulative chance of successful implantation over a number of embryo transfers, but such model is currently not available. So this is a model used to estimate the chance of implantation. It is an observational study and IVF data can be considered. Such models should at least consider maternal age, euploidy rate, and number of cleavage stage embryo or blastocyst transferred. And another approach is to use existing prediction models developed to predict chance of live birth following fresh embryo transfer. Example to include either Dillon model or IVF predict tool. Setting threshold for action. Threshold will guide clinical decision on whether patient should simply proceed to a further embryo transfer. This is the most important question which is asked. I have failed once, doctor. Should I proceed for another embryo transfer? Or whether investigations for factors contributing to recurrent implantation failure should be explored. So recommended threshold is 60%. Now, ASHRI 2023 recommendation, threshold for cumulative predictive chance of implantation to identify recurrent implantation failure for purpose of initiating further investigation is 60%. When a couple have not had a successful implantation by a certain number of embryo transfers and cumulative predicted chance of implantation associated with that number is 60%, then they should be counseled on further investigation and treatment options. So applying the recommendation definition of recurrent implantation failure in clinical practice, there is an example. I think it's a very busy slide and it can be understood by like the people who are just practicing only only the IVF. So the chance of pregnancy is 47% over the course of 2 embryo transfer attempted, 62% over the course of 3 embryo transfer, 72% over the course of 4 ET, and 80% over the course of 5 embryo transfer attempted. Now, if you apply an individualized definition of recurrent implantation failure in clinical practice, this is the ASHRI guideline. ART treatment following facility for fertility workup, at least 2 embryo transfers failed to result in pregnancy. Consider the cumulative chance of having achieved and implantation to date. So cumulative chance of pregnancy, implantation pregnancy less than 60%. Proceed with ART, not successful or successful. If you're not successful, again get back into the loop and you are again back. And cumulative chance of implantation pregnancy more than 60%. Recurrent implantation failure is suspected in couple. Follow up with RIF specific investigations and intervention. So you have to counsel the patient on their chance of pregnancy and the relevance of further testing and treatments. Before delving into investigations and interventions for RIF, let's first explore the potential risk factors and underlying causes of recurrent implantation failures. So these are the risk factors for recurrent implantation failure, which are modifiable factors like BMI, altered markers of uterine receptivity in obese patient, decreased implantation rate in obese patient is known. If BMI is more than 30 kilogram per square meter, significantly decreases the odds of implantation. As a matter of fact, it should be corrected before taking the patient into IVF. And on smoking, on female IVF patients, smoking for more than 5 years linked to fewer oocyte retrieved, higher cycle cancellation rate, and lower implantation rate. And male partners, negative impact on sperm motility and counts. It increases sperm DNA damage. Alcohol has negative effect on pregnancy and stress. It increases cortisol production due to stress risk factors of pregnancy, increases miscarriage rate by 2.7-fold, and failure of last IVF cycle leads to high risk of stress. Etiology of recurrent implantation failure, if you see, maternal factors, there are immunological factor, thrombophilias, endometrial receptivity, microbiomes, and chronic endometritis, anatomical abnormalities, male factors, embryo factor. And there may not be one single cause, but several factors working together leading to RIF. Among the etiologies, maternal factors include different aspects, and though a good quality embryo is foundation for successful implantation, the state of mother is also crucial. So etiology of RIF, maternal factors, immunology. Successful implantation is a process of maternal fetal immune tolerance involving various molecules, and we know trophoblast invasion can activate maternal immune response to fetal antigens. So during implantation, immune cells, including innate lymphocyte, T cells, decidual cells, and macrophages are activated, and they are associated with adverse pregnancy outcomes such as recurrent implantation failure, and increased Th1 immune response is observed in RIF patients. If you look into the maternal factors in RIF, there's thrombophilia, endometrial receptivity is responsible, which affects 2/3 of implantation failure, is responsible due to poor endometrial receptivity. Microbiome has come in a big way. So microbiome and chronic endometritis, I think, is a very, very important topic and very important thing which we should all look into. Microbiota might be involved in several steps of IVF-ET, including gametogenesis, implantation, and delivery. And patient with RIF display abnormal gut microbiota, but relationship between gut microbiota and implantation failure needs to be further investigated. Again, there can be anatomical abnormalities, fibroids, polyps, proportion of unidentified uterine anomalies, and most patients are asymptomatic and may remain undiagnosed until and unless they undergo transvaginal ultrasonography or hysteroscopy. But I'm sure this all must have been evaluated before patient is taken for IVF. If you look into the male factors, studies have shown that sperm affects early embryogenesis and placental function. There can be sperm DNA damage, there are protamines in sperms, and insufficient evidence of association between male factor and RIF has been found, and it is hypothesized that impaired sperm parameters are more likely to be involved in RIF by affecting chromosomal constitution of the embryos. There can be embryo factors. Embryos with abnormal chromosomes are recognized as important factors that cause implantation failure or pregnancy loss, and probability of chromosomal abnormality in embryo increases with age. So spontaneous abortion rate, 76% in first trimester due to chromosomal abnormalities. There can be complex chromosomal abnormalities. There can be common chromosomal abnormalities in RIF patients that can be translocation, inversion, deletion, and mosaicism. Now, investigations for RIF patients, ESHRI 2023 guidelines, these are the recommendations. So if RIF is suspected in the couple, follow up with RIF specific indication. There is a list of recommended investigations, reassess lifestyle factors, endometrial thickness, and APA and APS in case of risk factors. These are the things which can be recommended, like karyotype, 3D and ultrasounds again, and not recommended is like vitamin D testing, microbiome profiling, uterine NK cell testing. This is a whole list of exhaustive investigation, which is certainly not recommended. So investigation that are recommended can be considered, or not recommended if IVF is suspected, RIF is suspected in couple. So what are the now, let's get on to the final leg, interventions for RIF. Treatment of patient with RIF presents a challenge to clinicians. As all of us know, it is challenging. We cannot say that in the next cycle this patient will conceive if we have done all these investigations. It increases the likelihood, but we cannot be certain. There's no crystal ball in our hand. So various therapeutic options have been proposed to manage RIF, which includes lifestyle intervention, optimal IVF ET procedure, immunotherapy, anticoagulants, improving endometrial receptivity, antibiotics, again do a hysteroscopy, male factors, improve sperm quality, and pre-implantation genetic testing for aneuploidies. I think there has to be a crosstalk between connect between clinician and embryologist. They should discuss together and discuss about the therapeutic options with patients to address their questions and offer an individualized treatment plan. So treatment offered to the patients is again a big list of treatments which can be offered to the patients who are having recurrent implantation failure. Lifestyle intervention, as we have already discussed, like BMI, smoking, alcohol, and stress, they all have to be reduced. Optimal IVF procedure and ovarian stimulation protocol. Each unit has its own protocols and certain, standard operating procedures which people are following. I think it can be re-looked into, especially in cases of patients who have recurrent implantation failure. So you can reconsider stimulation protocol, either do a GnRH antagonist and HMG combination. So there are different things which can be tried, and important to select a specific protocol that includes ovarian stimulation and luteal phase support in patient with RIF, which may be related to the success rates. An optimal IVF ET procedure, embryo transfer, effect of age, higher implantation rate in frozen and thawed embryo transfer, no increase in pregnancy rate, analysis finding uncertain effect on live birth rate, and age might be beneficial for patient with RIF, and ASRM considered that there is insufficient evidence for benefit of age in patient with poor prognosis and including poor quality embryo, more than 2 previous IVF ET failure, and advanced maternal age. Considering influence of age on embryo and its controversial effect, it should be used with cautious. So optimal IVF ET procedure, when we really fail again and again, we keep thinking of more and more options. So with assisted hatching, that is AH, implantation rates were lower in fresh as compared to frozen thaw cycle. And especially in patient with RIF, there is a higher implantation rate in blastocyst transfer group as compared to cleavage embryo transfer group. And in patient with RIF with good ovarian response, implantation rates of fresh cycles were significantly higher in blastocyst transfer. So transfer of blastocyst in frozen thawed cycle might be a choice for RIF patient, and sequential cleavage and blastocyst embryo transfer appears to be beneficial. There are different things which can be tried, immunotherapy like glucocorticoids. So many of us are using glucocorticosteroids, prednisolone in patient undergoing ICSI with high level of peripheral CD69 plus NK cells. So, I mean, all doses and timings are arbitrary. I mean, you should be careful in administering this to patients and should have a specific indication. Immunotherapy, again, many of us are giving immunotherapy, IVIG, immunoglobulins, especially in patients with recurrent implantation failure, though it improves implantation, pregnancy rates, and immune abnormalities combined with aspirin and increased pregnancy rates. Immunotherapy, tacrolimus and cyclosporin are being used as an immunotherapy, intralipid and lymphocyte immunization therapy are also in use for recurrent implantation failure. I think anticoagulants, all of us are using aspirin and low molecular weight heparin in both in recurrent implantation failure and in recurrent pregnancy, early pregnancy loss as well. We are using. How can we really improve endometrial receptivity in cases where endometrial receptivity failure is suspected, either by human chorionic gonadotropin or peripheral blood mononuclear cells? It can be tried. And platelet-rich plasma, I think it is the flavor of the season, and it is come in a big way again. And whenever there is a failure, recurrent implantation failure or a thin endometrium, present PRP is being used to improve the endometrial quality, and GCSF is again being used. Doses of GCSF is administered at 60 to 300 milligram on day of HCG trigger or embryo transfer, and method of administration is crucial for effectiveness. Some people are putting it directly into the endometrium, some are giving it subcutaneous. So it is a different way of using GCSF. Can you improve the receptivity of endometrium? Like, endometrial scratch biopsy, scratching on day 7 of both the previous and ET cycle, improved live birth and pregnancy rate in patient with 2 prior ET failures. Endometrial receptivity assays like ERA-guided ET in receptive endometrium achieves clinical pregnancy rates compared to general IVF patient. Should we be giving antibiotics and hysteroscopy? Yes, antibiotics does have a role when there is a chronic endometritis, and treating chronic endometritis substantially improves IVF and ET outcomes. Hysteroscopy detects uterine abnormalities missed by HSG, and it removes lesions and corrects uterine shape, improving the live birth rate, and it is essential to address uterine lesion before the next IVF ET cycle. Male factors, severe abnormalities are linked to lower fertilization. So ICSI is usually what is being done these days. And what are the intervention for recurrent implantation? Other interventions, pre-implantation genetic diagnosis for aneuploidies. This is again invasive thing, but yes, this is something which should be offered to couple who have recurrent implantation failure. And there are several studies available to us comparing the effectiveness and safety of therapies and intervention for pregnancy outcomes in recurrent implantation failure. So in conclusion of this studies was IVIG plus growth hormone embryo medium enriched with HA could significantly improve pregnancy outcomes in patients with RIF. It appears that combination therapy is a potential administration strategy. I think cocktail works for everything. So this is just like a cocktail which you can use. And does supplementation with L-arginine improve endometrial thickness and enhance implantation rate? This is a study which I came across. It says that it increases endometrial blood flow for successful implantation, L-arginine. So if you summarize etiology and treatment options for recurrent implantation failure, you have to reduce the risk factors. You have to improve the maternal factors. You have to again check on the male factors and the embryo factors. And this is again the H3 guidelines for the intervention, which is being summarized. And lastly, there is no one size fits all. Model for supportive care for couples with RIF, but following approaches can be applied. Recognize the women couple as an individual. Something works for some couple, something doesn't work for some couple. Provide time for questions, information, repetition, and discussion, especially when patient couple is distressed and anxious. Listen to the facts and the feelings of the patient and couple. Show respect for patient, couple, and their wishes and choices. Use clear and sensitive language. Explain terminology. Avoid insensitive terms and mirror patient's preferred terms. Be honest about process, likely outcomes, and prognosis, and avoid false reassurance. Apply shared treatment planning in a partnership approach. Be kind, show concern, empathy, and compassion. That is what is called tender loving care. Does help in recurrent implantation failure and recurrent pregnancy loss. So thank you very much for patience listening. And I hope I have not confused you more, because implantation failure is not an easy topic, and all of us are equally puzzled with why implantation has not happened with even good embryos. So thank you very much. And if there are any questions, we can take later because, or maybe whatever the chairperson says.
Thank you, Archana ma'am. Like you have touched the nook and corner of the topic. Like literally speaking, like you haven't left any stone unturned. And as you suggested, it is a very vast topic and very, very difficult for us, like common gynecologists, to understand also. But you have beautifully given reasons why we should think about this failure. What are the indications for investigations and how to go about it? Thank you very much. How do we get to see the questions? I don't see anything in the. Do we get to see the question somewhere?
Ma'am, can we take the questions later because like we are running
Yeah,
short of time.
we'll take it later after the
Yes,
session.
yes.
Okay.
I'll be posting
So,
the questions in chat box, madam.
Yes,
okay,
ma'am.
okay.
Thank you, Dr.
And
Mumtaz, Dr. Naik, for
thank you, thank you, thank you,
Dr.
Dr.
MC for staying.
Okay, madam, we will all support you.
Thank you so much, ma'am, for discussing such an exhaustive topic in such a simplifying manner. And going forward, and we are having our next lecture by Dr. Facey Lewis, sir. And for that, I would request our chairperson, Dr. Nayak, sir, to kindly introduce our next speaker, Dr. Facey, sir. May I have the CV, please? May I have the CV of Dr. Facey, sir? Yes, yes.
Yes, can you hear me? Can you hear me?
Yes, yes.
I can't hear. Okay. It's an honor to introduce Dr. Facey Lewis, sir. He is a HOD and professor and HOD Department of Reproductive Medicine and Surgery at Amrita Hospital, Cochin. He was Foxy Vice President during 2021 and 22, and he's our National Executive Member and ICOG Governing Council Member. He's a Secretary of Kerala Federation Chapter IAGE and Secretary of Kerala Chapter ISAR. And he has been awarded. Hello, sir.
No, it's okay. I was secretary, not now. That was
Okay.
We'll see.
He received Foxy Corion Award and Kami Rao Yuva Orator and Imaging Science and Praveen Mehta Fellowship in Endoscopy and Suili Rudra Prize in Endoscopy and Kumud Tamaskar Research Prize and Infertility and so on. Welcome you, sir. Please go on for the next topic.
Okay. Thank you, Chairperson, for introducing me. First of all, let me thank. One second. Okay, first of all, let me thank for MP Chapter ISAR and UNS for this initiative, and especially the program director, Dr. Archana Besar, and coordinator, Dr. Kalyani and Dr. Rudra Agarwal for inviting me. Thanks to chairpersons, Dr. Chandrasekhar Naik, Ramya, Binish, and Mumtaz. I think with this, as you are running short of time, we will go ahead with the talk. One second. Okay, so my topic allotted to me is the thin endometrium and overlooked here in recurrent implantation failure. So, as you all know, one second. As you all know, the endometrial thickness is a prognostic factor for success or IVF, and always when we do the scan, the main thing what we see is that endometrium, how it is formed, that is where we implant our embryos. And assessment of the endometrium is an essential component of ART. And endometrial thickness has been identified as the prognostic factor of success of ART. When endometrium is assessed to be thin, physicians and the patients face a decision of whether or not to proceed with the treatment cycle. And the optimal thickness, all we tell is it must be more than 7 millimeters. Some tell it is at least it must be 8. usual ideal is between 8 to 12, and thin endometrium if it is less than 7. And we must also look at the pattern of the endometrium also when we see the endometrium. So the optimal thickness for consumption, the consensus is still lacking on what the precise definition of thin endometrium, whether it is 7, 6, because there are different studies telling that they got pregnancies got with 5 millimeter, and the pattern is also very important. So why this thin endometrium is important? Because it leads to poor growth of glandular epithelium, high uterine blood flow impedance will be there, decreased vascular endothelial growth factor production is there, and poor vascular development will be there. And the incidence, if you tell it is between 1.5 to 9% has been reported in the ART. This is one study which I got from Human Reproduction 2018. And it occurs to 2.5 to 5% of the IVF cycles, and which can lead to cycle cancellation and implantation failure. So it is definitely a key to the optimizing IVF outcome. And what causes this thin endometrium? Permanent damage to the basal endometrium, just like in Asherman syndrome, or history of uterine surgeries, infection, radiation, endometrial resistant to estrogen, reduced blood flow, and permanent damage to the basal endometrium. And in our countries, but luckily not in our part of India, the endometrium damage due to the COX is not much problem. But I had even heard a talk by the PGI professor about few years back. 10% of the patients coming to the infertility or OPD in the PGI Chandigarh of reproductive medicine unit had some in either previous or the active infection of tuberculosis. So, and other bacterial infections and sexually transmitted diseases and PID, so which can lead to permanent scarring of the endometrium. So the causes of thin endometrium can be due to iatrogenic causes, as you know, by the curettage or other Asherman's reasons, or infection like chronic endometritis or tuberculosis, hormone issues or vascular problems, and idiopathy. So if it is Asherman's, you must look for the any trauma like curettage, cesarean section myomectomy, or sharp curettage, or mechanical suction or manual vacuum, which can cause whether there was any history of that, or there can be other issues like septate uterus, biconate uterus, persistence of trophoblastic tissues in DNC and Murler and duct anomalies, residual trophoblastic tissues, tuberculosis, or any chronic endometritis that are the reasons for chronic inflammation. And the approach to Asherman's must be that all patients which are not completed the family, we must try to prevent when you do for DNC. So as far as possible, right now, if there is missed abortion, our policy is to prevent DNC as far as possible with the advent of the medical agents like misoprostol and mifepristone. And we must anticipate Asherman's syndrome and also timely surveillance and of the subsequent pregnancies. And we must be anticipating that in indicated patients. And if it is genital COX, acute or chronic infection can lead to destruction of the basal layer and endometrium. In India, as I told, genital COX is the most common cause of thin endometrium, but luckily not in our part of the in Kerala. Since healing takes place by fibrosis, it leads to the destruction of the endometrium and shrinkage of the endometrium. So regeneration of the endometrium even after complete treatment is very difficult, as fibrosis destroys the basal layer. So when thin endometrium, as you all know, reduces the chance, so immediately after the ovulation, what happens is the spiral arteries of the functional endometrium constrict and cause a reduction in the blood flow to the functional layer. So the reduced blood flow decreases the oxygen tension and implantation of the surface of the endometrium. And the theory by Robert Casper is when an embryo is placed over a thin endometrium is closest to the vascular trauma, the chance of implantation is less. So we will come to that subsequent few studies. This is one study which came in 2018, Human Reproduction, same study. Tells analyze in fresh ET and frozen ET. They analyze 40,000 embryo transfer, and the cutoff clinical pregnancy and live birth rates decline as endometrial thickness decreases below 8 millimeter in fresh IVF ET. and 7 millimeter in the frozen embryo transfer cycles. That is what their conclusion was, analyzing 40,000 cases. So there are many modalities have been applied to improve the endometrial thickness, but their effectiveness remain controversial. And treating the patients with endometrium is an ongoing challenge as an infertility, especially IVF specialists will be most of the people will be knowing that. So first of all, we must do in suspected cases go for hysteroscopy to rule out any additions, and if possible, we have to do the additional lysis. And always, if the cavity is obliterated, we must identify whether you are going into the false track or whether you are in the right track by identifying, if possible, by seeing the ostia and then do the proper additional lysis in the patient. So extensive fibrosis additions involving large portion of uterine cavity must go for hysteroscopy additional lysis. Next, we must do the methods to prevent the re-addition formation. So usually what practically we will do is a copper T after removing the copper, because copper increases the inflammation, and post-operatively we go for estrogen and progesterone therapy, especially estrogen. See the patient go for a cyclical estrogen progesterone therapy for minimum 3 months. And people have tried using Foley's catheter with bulb. That is really cumbersome. And there are intrauterine devices people have tried, but practically most commonly done is that an intrauterine device without copper. Right now, we don't have the Lippi's loop, so most commonly what we do is that copper T, we remove the copper and put that. And post-operative give with the estrogen and progesterone cyclically for three months. First, we give estrogen and 2 mg 3 times and see the endometrium, and they give the withdrawal bill like that. Cyclically, I have to go for at least 3 cycles, especially in extensive additions patient. And if needed, we have to go for a second look hysteroscopy, and remaining additions has to be cut in the subsequent months, even after 3 to 6 months after the therapy. So coming to the medical treatment, the most is the increasing estradiol. Oral is the most commonly done. Oral, estradiol valerate is there and estradiol hemihydrate is there. Both the studies is being, there are some studies telling both are equally effective, and none of the studies telling it is concretely telling whether hemihydrate or estradiol valerate is superior to the other. And extended estrogen regimes are indicated. Don't go for a minimum of 2 weeks. We can go extended if we can monitor if there is extensive addition is there. And some people have tried with low dose HCG administration also. I'll come to that. And there are other agents to improve the uterine blood flow, which is usually of the empiric utilization, like low dose aspirin, vaginal sildenafil, pentoxiflin, vitamin E, L-arginine, and regenerative medicine, like using the GCSF, platelet-rich plasma, bone marrow, derived stem cells has been tried. We will look into the evidence in each of that. So treatment by increasing estradiol estrogen taken is the key mechanism that regulates the uterine preparation to the embryo implantation, and simultaneous that facilitates the endometrial proliferation and improvement of uterine and endometrial perfusion will be there. And usually is recommended 10 to 14 days. And usual route is the oral administration, but there is percutaneous and vaginal delivery also is available. But some products of available orally has got a capsule or as a coating over that. So some products will not be easily dissolved in the vaginal administration. Only few of the preparations available can be put vaginally. In percutaneous, there are a lot of preparations are there as patches, and the gels are available even now in India. And this is one study which came in 2006 that mean endometrial thickness increases from 6.7 to 8.6 after extended estrogen therapy. So I just put this study to show that you may not restrict to 14. In this study, about the few patients, they had to go extended therapy, and one patient even up to 82 days they had to give. So that's especially in suppressed patients we can give. So extended therapy, if you give in a high dose, usually that will suppresses the HPA axis also. So extended therapy of estrogen can be given. And regarding to the transdermal, there are some studies telling it is superior to oral route. But patient complaints is always better, especially in our type of climate where the patient sweating is there. The absorption from the transdermal route is not as good as the oral. And this studies clearly tells that that it came in 2019 that tells that transdermal preparation of estradiol is superior to oral estradiol. That is what study which came into fertility sterility. So we can try a transdermal preparation also if the oral is not working, or the transvaginal also. So this is one. The other study I'll be quoting again in different categories. So this came in RBM online, which came in 2019. It was a management of thin endometrial acid reproduction clinical practice guideline from Canadian Fertility and Android Society. So in patients with thin endometrium undergoing fresh IVF embryo transfer, suggest against the use of luteal phase estradiol to improve pregnancy. That means if you are going for a fresh IVF embryo transfer, not in the frozen, they don't advise using routine usage. They're telling the data from their data there, that was their recommendation. So, and there the strength of evidence was strong. So and endometrial thickness in frozen IVF transfer, they're telling that for patients with history of thin endometrial ART treatment undergoing endometrial preparation, there is insufficient evidence that is any specific protocol, whether it is natural or hormone replacement and therapy for endometrial preparation. So there is no, they are telling that any of that things can be used in compared to the natural cycle. Hormonal therapy doesn't found any superior. That is according to the RBM online study about the Canadian study. So there are, but practically we all like to give endometrial preparation using oral preparation, and in not responding patients go for a transdermal preparation or the vaginal preparation. Only thing, vaginal preparation, we have to select the molecule which dissolve easily. Only few preparations are easily dissolved vaginally. So vitamin E, L-arginine, sildenafil citrate, this is the next category of drugs. There are, I just brushed through that to see show a few evidence, and there tells that the combination of tocopherol and pentoxicillin significantly increases the endometrial volume and improves the endometrial thickness. Also, these are the molecule, but I don't have any experience of using pentoxicillin. Vitamin E we use, but it is not found to be any superior than the from the estradiol, but it can be added as a co-treatment with the estradiol treatment. So according to RBN, patients with thin endometrial undergoing embryo transfer, there is insufficient evidence to recommend sildenafil to improve the pregnancy rate. That means, but people have tried using sildenafil, which improves the vascularity, but not routinely. It is not found to be better. And another molecule used is the aspirin. Also, there is no significant difference according to this study, came in 1997. Also, there is, if you look, can you hear? Okay. Also, there is some studies. This is one study came in 2000 telling that when you use aspirin, and it has found to be improves the endometrial thickness. So there are data supporting the use of aspirin in resistant patients. And regarding the whether you use GnRH agonist or GnR agonist or the vaginal or intramuscular progesterone administration, according to this Cochrane database, there is no significant benefit. But this Cochrane database, which came in 2010, there is no difference in pregnancy rate when no treatment was compared to aspirin, steroid, ovarian stimulation, or HCG. So there is no significant improvement with any of that. But practically, as I told, routinely, most of the studies recommend to use estrogen by different routes, and in resistant patients, we can go for other adjuvant preparations for that. So this RBM also tells that against the use of routine aspirin. So, but one interesting study when I referred in the literature is that innovative concept of the Papnicor, where they used 150 international units of HCG for 7 days with estrogen, and 8 milligram per day in FET cycles on endometrial thickness. But I have no experience. Other experts here can highlight that factor when we have got a wonderful panel, which will be moderated by Dr. Pashram and Kunjumoideen. And coming to the regenerative medicines like GCSF, PRP, and stem cell, there is varying literature evidence, and there is some studies which tell that the GCSF will work. This is one study which came to 2018, where they compared to control group. GCSF significantly improved clinical pregnancy rate, but it had no beneficial effect on embryo implantation rate. And that's why I just put the data, because there are some data supporting. But this RBM data, which they looked real statistical significance, they found that against the use of GCSF, just like aspirin and other recommendation, they were not properly supporting that. And regarding platelet-rich plasma, there are a lot of studies, even one study by the Indian study by our President-elect Sunita Tandulkar Madam, telling that it is found to be really useful when we are going for autologous platelet-rich plasma. What I found is that the real activation of the PRP is more important, and how you prepare the endometrium PRP is important. And it can be tried in really resistant patients, which we can try in PRP. Then this is like that. There are a lot of studies supporting PRP also. I'm not going to that. This is the Sunita Madam's study. Suggests the use of PRP as per promising in treatment of women with suboptimal. That means it doesn't routinely recommend for all patients. In those patients with really suboptimal endometrial thickness, even after routine estrogen therapy, it can be tried. And regarding the stem cells also, there are these are all platelet-rich plasma. There are a number of studies in the literature. Most of that tells it can be tried. And regarding the stem cell, there are two types of stem cells: adult stem cells and embryonic stem cells. Adult stem cells have low malignant protection. Thus are the type of use for the cell therapy. And this is the promising in patients with Asherman syndrome. Even though I could not get that, I had heard once the madam doing a study about stem cells in Asherman's people, and got some result in few patients. So it is promising. Regenerative therapy can be tried and easily available as GCSF and PRP. We have to do the proper activation part, and stem cells we have to really have the technical know-how about the stem cell. So, but RBM again tells that against the use of pentoxifilin HCG, gonadotropin agonist in suppressed cycles, platelet-rich plasma stem cells, because the evidence is weak because larger studies has to be needed to really tell about whether it will be really useful. But it is worth to try if you have the technical know-how in those patients. So coming to the genital tuberculosis, we have to clearly see that if the endometrial baseline is really damaged, gestational surrogacy is the successful modality. If the baseline is damaged and the patient is not getting improved after the all these therapies which we have tried, which I have mentioned already. And coming to lastly, one study. This is a study came in 2022. I just put it last so that They clearly tells that in fresh embryo transect, live birth rates increases significantly if the endometrial thickness is 10 to 12 millimeter, while the FET cycles is 7 to 10. But practically, to get about 10 millimeter is usually it's not always possible. However, an endometrial thickness less than 6 millimeter associated with a very dramatically less live birth rate, and this clearly you can see that in all the age groups, if the endometrium is increasing, it increases the increases the live birth rate, and up to this studies tell that after that is 15-16 millimeter, it starts coming down. That's why I just put that. So too much of endometrial thickness is also not good. So this is how this study clearly tells that if it is more than 18, the success implantation comes down. So to conclude, management of thin endometrium is really challenging. Endometrial tuberculosis, which is common in India, if the endometrium is destroyed despite anti-tuberculosis therapy, and if the ovaries are normal, we can go for gestational surrogacy. The extended estrogen regimes do not provide a solution for a big, but we can try in some patients. Low dose aspirin, vitamin E, arginine, sildenafil, GCS, and HCG has been tried, but efficacy remains controversial. Large randomized trials should be conducted to evaluate the method and dosage of these, which does have the larger recommendation in the larger studies. Use of platelet-rich plasma or stem cells. Preliminary studies are promising, but prognosis has to be guarded because in some all patients will not be beneficial with that. So we have to counsel because must not give false hope in patients when we are going for that. In spite, let me conclude by telling, in spite of large variety of treatment, most of the choices achieve only a minor modification in the endometrium thickness and have not been really validated so far. And this is, I'm quoting from the Middle East Journal, which came in 2018. And thank you for patient hearing.
Thank you, Fessy sir, for that elaborate presentation of the topic, starting from the etiology to the treatment. Sir, I do have a query. You have mentioned about the role of uterine blood flow in maintaining a normal endometrium. So we do find a lot of cases who have undergone uterine fibroid embolization as a part of treatment for fibroid and adenomyosis. So will you recommend UFE as a treatment modality for those who are
No, definitely. I don't think if the patient family is not completed, it is uterine embolization is recommended, because I have seen patients undergone uterine embolization and uterus became soft and patient has got irregular collection in the cavity even after hormonal therapy and withdrawal bleeding. Still patient presented with sudden gush of bleeding, and one patient I still remember when we had to open up for because of heavy bleeding, uterus was like just so soft and spongy like. So uterine artery embolization is not recommended for patients if patient family is not completed, but in emergencies conditions like if patient has got acute PPH, we have to go for it. That is different thing, but not as an fibroid. It is not recommended as a routine treatment modality.
Okay, sir. Thank you, sir. Sir, one question is there in the chat box. What is the optimal thickness for implantation of the blastocyst? What can we do to improve it? I think you have explained it.
That is, I had shown several studies. At least, at least 7 millimeter. But if it is 8, it will be better. 8 to 10 is the ideal thing, but we can get good implantation rate.
Thank you, sir. So your presentation was very clear, crystal clear, and very comprehensible for everyone.
But also, if it is more, there are some studies. I think I had read one study more than 13. I could not get that study. Only the study which I got was if it is more than 15, it is not good. I remember one study which I had seen 2 years back. If it is more than 13, also it is coming down. But the study which I got for while preparing is that more than 15, it is not good. But too much is also not good. But we have got pregnancies with above 5 millimeter, but the pattern is good, and we have got pregnancies. Even last month, I got one patient. Endometrium was not going to above a level, and we got pregnancy, which was 5.8 millimeters. That was the maximum, but that is not always. But the pattern is also important.
Good evening, sir. Dr. Kalyani here. Thank you so much for your wonderful talk today. Sir, I just had two questions. So first
The voice
is
is
there any
breaking.
role of probiotics in the cases of...
What
So can you
what
hear
is the
me now?
question? Yes, yes. Yes, yes.
So the role of probiotics in...
Voice is breaking, but I got the question. Probiotics. Probiotic usually I don't give for all patients. If the patient comes with failed implantation after one embryo transfer, then I give a course of probiotic. But there are because it was endometrial thickness, I did not go into that. There are some studies telling that routine those patients we have to go for an endometrial culture and sensitivity to see any infection and treat specifically, but routinely we don't do that. Probiotic, it is worth trying, but not for all patients, because it is an expensive treatment. It is not routinely recommended in any of the recommendations. What is the second question?
Any role of vitamin D?
Vitamin D. Okay. Okay. I think voice was broken at that time. I didn't hear. And vitamin D also, there are some studies. I think first study was by Manish Bangar sir in Indian population, where in IVF, I think from Indian study, it is found to be less, and it is really useful. What I do now is that to see vitamin D level, it costs nearly 2,000 rupees. So it is always better to give a course of 60,000 weekly once for 6 weeks. That costs hardly 200 rupees. There is no harm in giving 6 doses of vitamin D. So that also practically I am doing that. In the first cycle we don't give. In the second cycle, if the patient comes with one embryo transfer failed cycle, we give one course of vitamin D for those patients.
I think we don't have any more questions. Anyone wants to take any more questions? Okay, we got, I think, one more.
There is a question by Sujitra Mad. I think, what about mental preparation of patient? Definitely, counseling is very important. Counseling means not only the cost of the therapy, and also what are the chance of conception. And especially when endometrium is thin, we have to tell the patient properly and do it. That is the main mental preparation. Don't give false hope. Don't give a success rate, exaggerated success rate. And second thing is that now with the advent of more of antagonist protocol and freeze-all, role of endometrial preparation is increasing. And we can, and that's what one slide I showed about. There is a role of ovulatory cycle. So suppose the patient doesn't respond well with either with the routine hormonal therapy, there are some studies we can go for a natural cycle, or we can go for an ovulatory cycle in the patient and properly see the some patients, especially if we are going for a suppressed HRT cycle, endometrium may not respond well. In those patients, we can go for a ovulatory cycle in that patient. I think Kunjumudin Parshi will be putting those questions in the array of questions.
So thank you so much, Dr. Fessy, sir. It's always a pleasure to hear you. And it was such a wonderful talk. Thin endometrium, I think it's always been an enigma, a Pandora box. When it's open, it just keeps on coming out. So there's no end-to-end solution to it. But yes, we do gain by listening to you through all the scenarios that we all practically go through when we have the thin endometrium. So thank you so much, sir, for having joining us and accepting our invitation for today. Thank you on behalf of Dr. Basair as well. Let's move on to the next discussion. So the next discussion is the panel discussion. So in any webinar, I think panel discussion is always one of the part which we all look forward to, because it's always full of interactions and full of learning with a lot of scenarios. So today's topic that we decided was implantation interrupted, real cases, real challenges. We do have our moderators, Dr. Kunju Moidin sir and Dr. Parshuram Gopinath. Can we have the CVs for the introduction for the moderators, please? So Dr. Kunju Moidin sir, welcome sir. He is a renowned expert in the reproductive medicine and gynec endoscopy with over 27 years of experience. He serves as a medical director for Birla Fertility ARMC IVF and a senior consultant at its Posicod and the other centers. A leader in the field, he has held prestigious roles such as immediate past president of KFOG, chairman of ARMC Aegis Hospital, and former chairperson of ISA Kerala chapter. With extensive academic contributions and international faculty invitation, he continues to shape the fertility care across India, Middle East, and beyond. Welcome, sir. Next slide, please. Dr. Parshuram Gopinath, thank you so much for accepting my invite over just one message. He's a dear friend to mine, and we have been associated since so many years now. So to introduce him, he's a distinguished figure in the field of reproductive medicine and a high-risk pregnancy care. He currently serves as the medical and scientific director at SEMA, the Women's Hospital Kochi, Edapal, Thrissur, and Coimbatore, and is a leading faculty member for training programs. He holds the distinction of establishing the first IVF unit in the Republic of Maldives and delivering the country's first IVF baby. With numerous national awards, including the ISA Eminent Achiever Award and the ISA Youth Icon, he continues to shape the fertility practice in India and abroad, and through his academic leadership and pioneering clinical contributions. Welcome, Dr. Parshuram.
Thank you, Kalyani.
Let's have the CVs for the panelists for today. So the first panelist is Dr. Ekika. Welcome, Ekika. She is a dear friend, and thank you for accepting the last-minute notice for coming for this panel discussion. She is the president for MAO OBGY Society, member of Managing Committee ISAR, executive member of UP ISAR State Chapter, North Zone Coordinator for Foxy Young Talent. She holds a lot of awards, including Champion of ISAR 2020, Wonder Foxy Award by Foxy 2019, and multiple publications. And she does amazing research work being settled in MAO. She is one of the contributors for the role in RIF, the embryo glue, or retrospective analysis. Welcome, Dr. Ekika. Dr. Jisha Verghese, ma'am, she is a consultant reproductive medicine at the unit of Renai Medicity, Kochi, working in the field of reproductive medicine for the last 11 years, received Young Achievers Award from ISAR. She enabled the first child birth from Indian transgender community by fertility preservation, and her area of interest are reproductive genetics, PCOS, fertility preservation. Welcome, Dr. Jisha.
Thank you, Dr. Kalyani.
Dr. Sheila ma'am is the senior consultant. She is the former professor and head of Department of Reproductive Medicine, Government Medical College. She started the first IVF center in the public center in South India. Fellowship in Reproductive Medicine from UK. She has authored multiple books, including the textbooks of OBGY for undergraduates, active faculty in national and international conferences, and more than 20 publications in index journals. She has been also awarded the PhD for a community-based study on PCOS. She has won the Rotary Best Doctor Award. Welcome, ma'am.
Thank you.
Please. Dr. A.B. Koshi, sir, he is the consultant in reproductive medicine and surgery with Sunrise Assisted Reproduction Center in Kochi. He has completed his DNB and MRCOG and FRCOG. Can we just mute Mumtaz, ma'am? He has published more than 14 articles in the peer-reviewed index journals, contributed 7 chapters in different books, peer reviewer to 11 international and national journals, editorial board member JHRS, and guest editor eJob South Asia. Dr. Rudri, would you go ahead with the rest of the panelists?
Yes, ma'am. Thank you so much, ma'am. Going forward, I would like to introduce our next esteemed panelist, Dr. Mahesh Korigil, sir, with us. Sir is senior in fertility specialist in Nova IVF, Bengaluru, and Sir is one of the National Strategy Director of Nova IVF Fertility. Sir is holding so many various prestigious posts, and Sir has hold so many teaching positions. Sir has been a former assistant professor at JNMC Belagavi, and to his credit, there are so many multiple publications and awards. Sir has published 5 research papers at international index scientific journals as the first author and co-authored several textbooks of infertility. Heartiest welcome to you, sir. Next, we have Dr. Madhupriya ma'am with us as our esteemed panelist. Ma'am is clinical director and senior fertility physician at Nova IVF Fertility, MRC Nagar. And to her credit, there are so many awards and publications. She has special interest in biological hair for poor ovarian and poor sperm reserve patients and in oncofertility. Welcome you, ma'am. Next, we have Dr. Dipti Surendran with us. Ma'am is a fertility consultant at Nova IVF, Palakkad, Kerala. And to her credit, there are multiple awards, and she has been a university topper in her MS in the Kerala University of Health Sciences 2020. She is holding the membership of SR and PUGS. Welcome you, ma'am. Then over to Dr. Kunju Mohiddin sir and Dr. Parshuram sir for the conduction of the panel.
Yeah, thank you, Dr. Kalyani and Dr. Rudri and the entire team for giving us this opportunity. And as I heard from previous 2 speakers, they made the concept very clear. And myself and Dr. Parshu will make it, at the end of this panel discussion, we will make it very confusing. And so that you will go back and read further. So basically, the panel discussion. Let me share the screen. Yeah. So the implantation interrupted, real cases, real challenges. So you need not worry. The heading is nothing but recurrent implantation failure. We'll be just bringing about a few case scenarios. All the panel experts have been introduced well. And do we have any absence? I think I couldn't see Dr. Ekika. Is she here? All others could see.
Actually, she was not able to join us due to family reasons.
That's okay. So we will just move on to the presentation. And one thing which I want to convey that the panel discussion presentation was not communicated to the panelists because as it got ready in just half an hour before. So we'll just have a very good interactive session. And it is nothing more than what the previous 2 speakers have elaborated, but we'll have some different situations. So as an introduction, it is basically what we all have to understand. It is distinctly different from recurrent pregnancy loss, which is a disorder defined by ASRM as the loss of 2 or more consecutive clinical pregnancies until 20 weeks of gestation. So here about ART has improved outcomes for struggling couples, and recurrent implantation failure refers to case in which women have had 3 failed in vitro IVF attempts with good quality embryos. The details of it will be elaborated by our expert panelists. Multiple failed cycles can leave couples frustrated and desperate for explanations. As the IVF centers are mushrooming up every day, and we have a lot of IVF centers, there are a lot of failed IVF cases as well. And around 5% of women suffer from 2 consecutive pregnancy loss. Almost 70%, 75% are due to implantation failure and therefore are never recognized as clinical pregnancies. So shall we start with Dr. Ebi? See, why the common definitions of RIF is unacceptable. After at least how many failed ETs? Would you define RIF? Do you count ETs performed at other IVF centers? Because it's a big question mark. Do you, because very often you will not have the details of the ETs performed at other centers. And do you define RIF based on the number of embryos that fail to implant? Please elaborate, all of us.
Yeah. In fact, the major point is that there is no standard definition for RIF. That means we don't have a consistent statement like, say, for PCOS, we don't have a international definition for RIF. Now, most authors or most scientists who are looking into this area really talk about at least 3 transfers of good embryos and preferably blastocysts. It could be fresh, it could be frozen. And like what you said, in India, the major issue has been documentation. And when you don't find documentation, it becomes very difficult to say that it's a true RIF also. But in case you have the documentation or you know what the quality of the embryos are, if you've transferred 3 times and it is not implanted, preferably blastocyst, then I would be defining that patient as a case of RIF.
Yeah, like you said, here in India, just like the number of IVF centers are too many, we do not have a proper standardized discharge report or the documentation regarding the how many embryos transferred, at what stages transferred. Very often you see unfertilized oocytes, and we don't know what has happened to those things. So situation is not as simple as we think. The definition you can read from any textbook, but I want to highlight on this point, that is the documentation. You may not be able to achieve a good pregnancy or a successful pregnancy in a patient, but it is our moral responsibility to give a good documented report. How many how was the stimulation, how many oocytes were retrieved, how many got fertilized, what was the state of the embryos at day 3, and how many embryos have gone to day 5. Another challenge is based on the definition, even though blastocysts are being considered, not many centers are still doing the batches, and they do only day 2 and day 3 transfers, because whatever said and done, the situation is not that light. Just request my co-moderator, Dr. Parshu, to enlighten further on this and your viewpoints.
Yeah, there's one particular thing that I also like to bring to everybody's attention is basically when they talk about 3 transfers. See, now one thing that we all think of, or one more debate that I want to put into this question is, every time we talk about 3 embryo transfers. Now, when we say that 3 embryo transfers, how important it is. When you say 3 embryo transfers are from the same womb pickup day, whereas it is 3 embryo transfers from different womb pickup days. Why I'm saying that is because, see, for example, in an womb pickup, probably a patient who's having multiple number of oocytes, see, anything during that particular cycle could have actually affected, whether it could be the media batch at that point of time, the gonadotrophins at that point of time, could be the incubator settings at that point of time, could be so many things can that particular batch of embryos. So it's the same batch of embryos. So when somebody comes to me and says that, okay, I've had 3 failures. So when always one thing that I always ask is, but was it from how many pickups? Was it just 1 pickup or 2 pickups? In both the pickups, it had the same thing. So because I feel that probably 1 pickup and having 2 failures, okay, yes, in a good center where everything is perfect, when you're talking about a very idealistic society, yes, we might understand that as, okay, 2 failures is 2 failures. But then if you're talking about a single IVF cycle, 2 failures or 3 failures, can we consider it as only 1 failure, or should we consider it as 2 or 3 failures? Somebody can, this is my thought process. So Sheila madam, I think with the vast experience,
I agree with you, Parshu. I think that's a very valid point that is. All of you embryologists will agree is that if with the same batch, how many times? There's no point in getting more and more embryos in the same batch. If you're not in the first or second, usually you have to get a pregnancy. It is an ideal. Usually you get a pregnancy if they're good embryos. So third, fourth, and all, I do agree, but the definition doesn't allow that. But always look into that. As you said, I also go into that. We ask them. With the center is very important. The documentation, how well they have given us the documentation, even after the ART Act, the documentation still remains the same. I'm very sad to say. There's nothing given. You're supposed to get at least, if not photographs, at least, isn't it?
The story of photographs is, we know.
The story of photographs is also, we know. There's no point in absolutely. But
yeah.
Parshu, that's a very valid point. And
I just want to say, I just want to ask, will you consider if the previous OPU or previous transfer is not properly documented? Do you want to say that we need not consider?
No, I can't. You can't do that, isn't it? Because the patient is in front of you. Practically, even though we would like to do it, it's not possible. Yeah. Patient is sitting in front of you after 3 transfers, and then she's very upset whether she's done it in A, B, or C center. So we have to take it seriously, look at the records, go back, check. Absolutely.
Sir, another aspect.
Yeah, please.
Exactly opposite of what Parshu sir just mentioned. If the embryos were very good, euploid and endometrium was all good, even if
failure of two embryo transfer, I mean two embryos together, then that itself is a risk factor. No, we have to consider it as a probable candidate for further implantation failures, and we can go for further workup and like that.
Yeah, what you said is practically very important because for the patient, even one IVF failure, that means by whatever means, whether it was a poor quality embryo, good quality embryo, documented, non-documented, whether you put one blast, a single blast, or whether you put two blasts, for them, one IVF failure, it is a failure. Mentally, and see, they came to another doctor, another center. They want to know why the previous one was failed. How can we make it better? So for them, even one failure is important, like you said. Harshu?
Yes, sir. This is basically for me, like I said, my primary thing whenever I'm counseling a patient is, yes, we should respect and we should kind of consider the fact that they've had 3 failures. But in back of my mind, it'll be always like, yeah, it's one failure, which is the clinic they've done from. Probably what is the tentative of this thing. So all those things play in the back of my mind when I'm talking to a patient. So when I feel it's just probably that one time and then it is not doing well, I always tell them, let's say, you never know. See, it can even happen in our own center. So it's not that people see, when you say even in our center, when you're having three transfer failure from the same patient, we always tell them that next time it could be okay. While we're talking to the patient, we always tell them that, like, yeah, next time is a different lot of embryos. Probably the lot of embryos that were developed at that point of time, whosever fault it may be. It could be our fault. It could be the patient's that time's cohort fault. It could be any reason, because we have seen our own patients do well after 3 failures or 4 failures in the next cycle.
Even the fault of air quality.
Yeah.
I think we should not be judgmental here as far as whichever the fertility center is doing. I think a fairly decent job can be done. Most of the fertility centers, I mean, I don't want to blame, but then we have to consider that as a valid cycle only. Whatever has been done, yes, it's an attempt. The problem is if we don't consider it again, we are going to start from the scratch, and it's already huge money patient has already spent. Better to be cautious than repent later, considering, oh, it was right, it was not, it didn't come out well and all. So let us consider the previous cycles done, no matter they must have been done from different unit, as a valid attempts, and then we have to take the precautions going forward without any much of a.
So one thing to add.
Yeah, please, Disha, please.
Sir, actually, I have come across a study where they were telling that when you have multiple number of embryos, like they have attained a live birth and they have done a transfer, they have surplus embryo to freeze. That means that they have a good oocyte quality and the sperm quality and the embryo quality is good. So surplus number of embryos and surplus number of embryos to transfer can be a good prognostic indicator for the embryo quality.
Yeah, but that one, that has to be taken in a different perspective also, because surplus means it should not be super surplus. See, when some patients have thrown 40 eggs, see, naturally we know that 10 eggs, 12 eggs, 15 eggs optimum, then suddenly you get 40 eggs, you don't feel sad, but you feel little bit happy. Then you get some 18 or 15 blastocysts out of that, you can assume that majority will be aneuploid. So that study also is there. So like what you said, Dr. Jisha, it should be surplus, it should not be super surplus. Okay. Madam wants to add something. She was trying to tell something. Shira, madam, you were trying to tell something? No.
No, just about somebody mentioned euploid. How many of us are routinely doing PGTA? Because in some of the definitions, we are all looking at the embryo quality, blast, this thing. Embryo PGTA is not routinely done, isn't it?
Yeah, because PGTA is something which we are not routinely done. It
not
is
at all.
for failed patients or
It's
some
not
advanced maternal age or something.
only in such cases. RIF, yes, I agree.
And guidelines do not support it.
Not
PGTA.
support.
So we'll move on to a case scenario so that all of us will be confused equally. 39 years aged female, 4 failed FETs. I think, Sheila, madam, you can mute. Some disturbance is coming from your mic. History of 4 failed FETs from elsewhere and previous history. First OPU, 8 embryos, day 2 embryos. First ET, 3 grade 1 embryos. Second ET, 2 grade 1 embryos. day 3, and remaining embryos didn't survive. Second OPU, 5 embryos, first ET fresh transfer day 3, second ET blastocyst transfer, it was a thaw culture. So presently, she is 84 kg, regular cycles, husband IT professional, usual husband combination in almost all the panel discussions, and smoker on diet and exercise program for pre-diabetes and how to proceed. So that we will just putting across some. Parshu, you want to add something into this case scenario? Make it more confusing?
I think she's already 39 years.
Yeah, Mahesh, please tell what are the risk factors you can see in this patient.
Age itself is a bigger risk factor at 39-year-old in an Indian woman.
Yeah.
So there are higher chance of having an aneuploid embryo in her case. Especially if I see the history, day 3 embryos have been attempted most of the times, other than only once at a blastocyst.
Yes.
So maybe clinician was not confident of them going forward into a blastocyst stage. That why maybe day 3 embryo was transferred. It means that there is compromise in the embryo quality already. The number of eggs are good, surprisingly, for our age. But given the number of eggs, blastocyst should have been attempted even in the first time, which was not done. A day 3 transfer was done. That is number one. Number two, to think about the male factor of smoking, that could be a factor. If a male factor was there, then the blastocyst formation also would have been a little bit of a problem. But here I am seeing a blastocyst also has been formed. So yes, smoking is a factor which affects, but then I don't see that as a major factor in this scenario as blastocyst has formed. So I think he has to stop smoking. There is no doubt, and the lady has to reduce the weight. But definitely, since she is above 35, I feel pre-implantation genetic testing of the embryos has to be done, along with only after she has starts on lifestyle factors like weight loss, and husband quit smoking and put on maybe some antioxidants.
Yeah, Dr. Jisha, can you tell us something? Because see, after this initial definition part is settled, this panel discussion will be over. Rest of the things will be a repetition of what the previous two speakers told. So how does maternal age affect your definition? Because will you consider the, like Dr. Mahesh has told, there can be a lot of aneuploid embryos. So in that scenario, a 25-year-old woman coming with previous 3 failed transfers, and 13-year-old woman like this came with previous 5 failed transfers, will the maternal age has the influence on the definition? We all know that maternal age can be a factor for IVF failure, isn't it? But in definition, does it has an influence?
Yes, sir. Actually, according to the recent ESHRE consensus, they have said that we have to take a cutoff or threshold level of 60%, and the 60% of implantation potential, and we are failing to have a pregnancy. That is what they have defined as RIF. So if the woman's age is less than 35, if untested blast is transferred, 3 transfers, we can call her RIF. But 35 to 39 years, again, 4 blast transfers untested, or more than 40 years, it has to be like 5 ETs, 5 blast ETs. After that only we can call her that like she is having recurrent implantation failure, because the aneuploidy may be the reason for the other failures.
Yeah. So that is the impact of age. She has already mentioned that except in the, even interestingly, in donor using donor oocyte yields higher implantation rate regardless of maternal age. So here age and implantation rate that quite varies from the less than 35 to more than 44 years of age. Dr. Parshu wants to add something with regard to age.
Nothing.
Yeah. So we'll move on to the next one. So the obesity, how can we correlate? Dr. Madhupriya, are you there?
Yes, sir.
Yeah. Kindly elaborate us on this BMI. So should we add this into the definition or some, because this can be an obvious reason for failure, isn't it? So
yes, it can.
Normal BMI patient in the restricted maternal age, maternal age of less than 35 with good embryo transfers, only those patients to be included, or if there is a reason like this BMI, increased BMI?
Of course, the standard definitions of RAF, which have so far been identified, do not include this BMI. They have included the age of the woman less than 40 years and more than 40 years, and then the number of embryos transferred, and they have not included fresh or frozen. But the recent definitions have included both fresh and the frozen embryo transfer cycles.
BMI
But
not included. Yeah.
yes, there are certain factors like BMI, the obesity, like the lifestyle factors, other lifestyle factors like the smoking and others like pre-diabetic status of the patients, both the husband and the wife for that matter, because both of them contribute to the embryo. In case of cell cycles, having a high BMI, having a high weight by height ratio for both the woman as well as the man can impact the quality of the embryo. Not more so to emphasize, yes, aneuploidy status of the embryo is very, very important to be checked when they have more than 3 embryo transfer cycles which have failed, despite having seemingly good blastocyst or seemingly good day 3 cleavage embryos and a good uterus lining. So decreasing the BMI, some of the studies, though not all, have seen that there is an increase in the clinical pregnancy rate in those coupled with recurrent implantation failure, that is more than or equal to 3 embryo transfers failed. When there is a decrease in the BMI and they are going ahead with a new cycle, just like in case in this couple, if they have to go ahead with further transfer, they may need another cycle because I see that there are no embryos which are available. So decreasing the BMI and then going ahead maybe at some point can increase the quality of the oocytes in the woman, and the chances of sperm DNA fragmentation could also be decreased if in case there is an increase in the DFI due to the obesity in men. So definitely this is something which has to be studied and included at some point.
Yeah, so let me put it across something like this for all the audience, all the delegates. They want to know if this particular patient comes to you, what will you advise? Before, will you take her up straight away by telling some, okay, we'll do PGTA this time and we'll do try again, or will you advise her to reduce weight? If you advise her to reduce weight, what will you advise? Because everybody wants to know. Everybody knows that obesity kills.
Yes. I would like to know her BMI, and normal BMI for an Asian woman, for an Indian woman, I would consider that to be between less than 25, if not at least possible. Overweight is between 25 to 29 BMI. So if she's going to be more than 30, definitely there is a way that she has to reduce with diet, with exercises. And it's very important. I would say the importance, counseling is very important here to tell them, because they have had frustrations because of multiple failures. It's important to jot down right from the age, right from the lifestyle modification that both of them are going to do. There can be a change that they can make, up to what percentage that can be made in the next cycle, because there is going to be new embryo which is formed. So improving the quality of the oocytes as well as the sperm is going to be really helpful, and decreasing the BMI, coming to the ideal body weight when it is less than 25 BMI is going to be helpful. If not possible, because of the restriction in the timing, she's 39 already and I do not want to waste much of the time, then she's going to actually be at least less than 30 for us to start a new cycle.
Yeah, Parshu, do you want to raise up some issues in this?
The whole challenge again here is
balance has to be done between the age. So mainly we have to see age here. We know that after 37, the decline of the ovarian reserve is very fast, and weight loss is not going to happen in any time soon. It will take some time. So we need to balance the age with the weight loss here. So I think going ahead with the freezing of maybe a pooling cycle of the embryos is good enough. Before maybe embryo transfer, we can delay, maybe give her a time to do a weight loss regimen. But here, waiting will bring down the oocyte quantity and quality further, because there is a rapid fall in the both the parameters of quality and quantity. I don't think we should wait here. Maybe pooling cycle.
And sir, for her age at 39 years, stressing on reducing BMI to less than 25 would be frustrating for her also. So rather than, we can give a time of maybe 1 or 2 months with a proper lifestyle advice and a proper calorie deficit diet, and that is enough. Now, why to stress her with this reduce the BMI and all that?
I think
We can counsel, but
yeah,
yeah,
Parth,
I think,
you were
see, I
trying to
think
tell something.
no, I know the same thing only. I think risk versus benefit. No, that is what we look at it. I think Dr. Madhupriya was not insisting that they lose weight and come. I think we look into several aspects. A very idealistic scenario where they are going to lose weight and come back, a very motivated patient who's very convinced, is very sure that they want to go try and give it. We can
And
give it
if
time.
she were to be
But,
younger, it would have done different.
but the time again is that whether within 2 or 3 months, whether 39 plus or 39 plus 39 years plus 3 months is going to make a big difference, or 39 plus 2 months is going to make a big difference. Nobody knows. See, none of us can actually predict how much difference is going to make. Idealistic scenario, yes, but if you feel the patient is not cannot, or talk to the patient and see if this is something that you think you can do, something that you feel that you will be able to do, then probably do it. But otherwise, from my point of view, is also very similar to yours. Probably, I think waiting and losing time, having more number of embryos, to transfer is a possibility that one of those embryos might get implanted. So like you said, if it's a 5 or 6 in a normal person, you need to have at least say 8 embryos to have one live birth. Probably this patient will need at least 16 embryos to have one live birth, right? So so probably more the number of embryos you have, more chances. But like I said here, it is a more idealistic scenario that we are looking at. If things are possible, yes, but otherwise I don't think we should waste too much.
So to make an idealistic scenario, do you recommend the bariatric for this patient because her BMI is 32?
No. Sir, now Banjara is there, sir.
So there are two.
No,
So there are 2 points I would like to add here. Number one, how
Short
much
points,
is
short points, no paragraphs.
yes, short points, 2 things. One, BMI. High BMI is always neglected. And in view of all other factors, here we are thinking about people who have already had frustrated cases, because 3 times the embryos have all been pooled and then transferred and they have had implantation failure. So if every minute factor makes an impact there. So
But
BMI
Parthi wants to neglect it again. He wants to take the eggs and neglect it again.
it's important to tell them about implantation as well as about the embryo quality, which can make a lot of change if she's in that frustrating status, sir.
Yeah. So we
No,
may
I'm agreeing with both. I'm
Yeah.
agreeing with both. And okay, somebody did talk about the bariatric surgery. I think, I don't know. I think definitely there was I think evidence coming in, or probably there was some thing coming saying that in patients with bariatric surgery, the ovarian reserve, probably I think even what we have seen in our own real-time patients is like post bariatric surgery, the ovarian reserve seems to be slightly compromised. I have absolutely no idea exactly why it is happening, but I don't know. I want the other panels.
Yeah, I just want to comment because there are level 1 and level 2 bariatric surgeries. So if you go for bypass or something, then it will be detrimental. It can be detrimental, but there are simpler procedures where we reduce the volume of stomach that will transiently reduce weight. It is not going to have a permanent weight reduction, but it will transiently reduce weight so that you can have a better treatment outcome. Abhi is there. Abhi is from a center where bariatric surgeries are happening. Abhi?
Well, we have any significant drop in the ovarian reserve as such, but in this scenario, like age is a more important thing. So I would be more inclined to get her eggs out, freeze the embryos, then maybe work out on the weight loss part. And in a woman who is probably not lost weight till the age of 39, diet exercise is unlikely to work in most cases. You might need something more drastic than that.
Yeah, so we will continue with we'll leave that confusion for the audience again. So the smoking part, Abhi, we'll just continue with smoking. That guy, can he continue smoking and take antioxidants? Can both work together? And
Yeah, ideally, he should stop smoking, and we do have smoking cessation medications also now. So that's something which can be done. Nicotine patches can be given, and that does make a difference. And something like DNA fragmentation test might be also useful in convincing the patient that, look, your sperms are of a poor quality, and that can be improved to make the embryos better, and obviously with a better result after that.
Yeah, DNA fragmentation test can be used as a counseling tool, even though not without much, it is not with much evidence backup, isn't it? But see, you are showing on record that your smoking has this much impact on your sperm, so that can be used as a counseling tool. And so, what all pathophysiological mechanisms might be playing in? So, Sheila Madam will teach us, like what she teaches in her college.
No, what are you? I didn't understand the question. What are you actually?
Pathophysiological mechanisms which can play this particular patient. Just
I think so many things, no? The endometrium has to be embryo. We assume that the embryo is good when you say it's a recurrent implantation failure. So the endometrium is also there, and the endometrium has to be good. Look for the anatomical factors, immunological factors also do play a major role, and that's where it's a very big gray area, isn't it? Then what is it? Looking for you're doing your C endometrial CD4 C count and all that, but I don't know how many of us are doing it. I'm not doing it. So all these things, yes, immunology, infections, and more anatomical factors also, like previous, all those things.
Yeah, at this point, madam, I just want to put it across because infection is which is much neglected part. We will overlook into it, and the antibiotic abuse that will make most of these infections very much resistant. So at this instance, along with this, I would like to get a clarification from you. What can we do? Yeah, I think you also need an antibiotic.
I need an antibiotic. That's why exactly. That's why I'm muting myself in between.
Yeah, at this point, I would like to ask a clarification regarding what are your recommendations or suggestions or guidelines when you happen to see persistent fluid in the endometrial cavity?
Yeah, persistent fluid in the endometrial cavity could be it could be an undetected hydrosalpinx, and you have to be on the lookout for that. The second thing is infection also. So in such cases, yes, you can look for chronic endometritis, or at least give antibiotics if you do not have the benefit of doing that. But you can do a culture. You can do a hysteroscopy, remove this thing and do a culture. Hysteroscopy also has to be done, and a culture can be done.
Can it be physiological, madam? Because everything is done, nothing is negative. Can we just
sometimes we do see it, and then and now another thing is, suppose she has not this patient, a previous section, ismosil also has to be looked for. But even without all this, sometimes we do find on the day of till that everything was fine, and then you find fluid in the endometrium and you have to cancel it. But the next time it doesn't recur. So it can happen also in an individual this thing, probably your stimulation or something.
So, madam, so one thing to add is, say, for example, a lot of these natural collections that happen do tend to also disappear once we start the progesterone.
Yes, many of them do tend to disappear.
So probably we'll have to take a decision on whether to do a transfer on the day of consent.
That is very.
After reassessing the scan, correct?
Yeah,
I'm not very happy. Once I don't know what is this thing. You had a fluid this thing, and then when you start
before telling physiological, we have to rule out all pathological reasons. That's the main thing.
Definitely, yes.
Kunjali sir, I think
yes, please.
The part about that anybody is doing all these immunological tests, because today now that is the hottest topic, and anybody is doing here immunological tests. Even we are not doing any view on it. Mahesh, in Nova.
No, sir. We don't do.
Nobody is doing it, I think. Everybody talks about it, but I think nobody does.
Nobody's doing it. So we're still not convinced.
What we need to understand is that in nearly all cases of recurrent implantation failure, we know what is the cause. It could be a bad embryo or a bad endometrium or a bad patient. I think we should be worried about in only those cases where everything is absolutely fine. And that is probably that area where you might be thinking about immunological cause. That's a very small number of patients.
I mean, this belongs to bad patient.
Yeah.
No, it's not only, we're not sure about I think she is a candidate for PGT also, isn't it? 39 years and so many losses. So that's also.
Now we'll move on. Deepthi, can you just enlighten us which anatomical malformations and gynecological aspects do you consider in the definition? Again, we have not left the definition behind. So which techniques are applied in your center to investigate anatomical malformations or gynecological aspects? Dr. Deepthi, are you there?
Yes, sir. Yes, sir. So the most common cause for RIF or RPL is septate uterus. So I think with a good 2D ultrasound itself, we may be able to identify a septate uterus. But if at all we are not able to, then we can confirm it with a 3D ultrasound. And for this patient, if at all we are getting good blastocyst, like in the next cycle, maybe we can consider a 3D ultrasound or even a hysteroscopy prior to the next transfer. If at all, even if the endometrium looks good, we can counsel and we can make a shared decision making with the patient. If she is willing, we may go for a hysteroscopy as well.
So this patient who already had undergone hysteroscopy, it was mentioned as normal. But the ultrasound, because you had a latest ultrasound machine and you found out a very small septum, subseptum, will you do hysteroscopy again and cut it?
No, sir. No need, sir. I think if one prior hysteroscopy, there is no septum, and if the septum looks small
No,
in the
your
ultrasound,
ultrasound already detected a septum extending up to 1/3 because you have latest machine.
sir, if I'm sure about that, then definitely I'll just give a look. Give a look and then we'll decide according to the
Take
hysteroscopy.
money and leave it.
Sir, if the septum is too large, then I'll definitely
it is
consider.
extending. Ultrasound is having very high resolution. It is only 1/3. Your ultrasound is super and you are a very good sonologist.
Sir, I will look into the endometrium again because
you want to make it more confusing?
No. Okay, I'll just go back to the basic question. I know this again. I know people. I don't know how will they take this question. Now, a septal uterus, whether it is subseptate, does it cause infertility or does it cause RPL?
RPL, absolutely. That is the question.
Does a septum cause infertility?
Actually, we are not sure. It's mainly recurrent miscarriage. But when you see a septum and the patient is for a complete septum and the patient is for IVF, you might as well do it. But that is not to prevent. It is to prevent a miscarriage actually. But you will do it. But in this case,
the problem is, madam, see, a lot of times what we have seen is they come for RPL and then we find a septum, we'll cut in the septum and after that they will never get pregnant.
They never get pregnant. Correct. You're very correct. There are some studies coming in, isn't it? Whether to do or not.
And have you seen recurrence of septum?
That is because re-addition there can have some re-addition formation can happen. No,
but the problem is like in the same septum, previous septum, there can be recurrence of the septum.
It can happen.
But for this patient, this particular patient, would you leave that septum alone or?
No, I am asking you can't ask questions to moderator. Moderator.
No. So let me come in. I agree with Dr. Kirti on hysteroscopy point. Because number one, yes, septum, if it is there, if it is subseptum is there, or a small polyp is there, it can be ruled out. That is number one. Number two, since it's RIF, one of the most common, one more cause is the endometritis. So most of the endometritis features you can appreciate in hysteroscopy. You can see micropolyps, you can see hyperemia, you can see the features of endometritis nicely if you're doing a hysteroscopy. I think even that will help us, especially in RIF. There is a bigger correlation with the
Mahesh. Here the question is this patient gives a report of normal hysteroscopy. Now you bought a very good new ultrasound machine and you found a subseptum extending up to 1/3 of the uterine cavity. Will you do hysteroscopy again and cut it?
Yes, because of these reasons. One is we don't know the competency of the surgeon who have done it, because we have seen many a times the septum has not been cleared well because of maybe the lack of training or anything like that. That is number one. Number two, it could be an intrauterine adhesions also. We need to check it. Number three, simultaneously, I want to see endometritis here, which is more interesting in case of RIF. These three reasons I would like to repeat hysteroscopy.
Yeah, Sheila madam, she wants to tell something.
I would do a hysteroscopy, same reasons, just to find out what exactly, like chronic endometritis is where it can be picked up easily. That is also there, and looking for a polyp. But whether I will cut a septum, which is just, it depends on, if it's a very, if it's just what should I say, then I might not cut it, because 1/3 of the cavity is what you said, isn't it? Or the one, isn't it?
Yeah.
So actually, it's the how much you have to measure it properly and then see. If it's more than 1 centimeter, I would not. Only if it's more than 1 centimeter, 1.5 centimeter, I would cut it.
Means
that was
yes, Parsu?
Yeah, that was the question that I had in mind. See, for example, when you talk about cutting a septum, now which septums? Obviously, if it's a long septum, you will cut it. But smaller septums, for example, this that you see a small indentation from the top, subseptate or small indentation, and you're seeing a reasonably good spacious cavity below. do you think, see, technically, logically, if you think at it, does this actually cause infertility? Because it's not those thin septum that is coming. It is only going to be injection. See, the mostly the lining behind is reasonably good. The muscular structure of that septum is reasonably thick enough. Will it actually cause infertility or RPL? By cutting it, probably are we causing more harm?
Additions.
More
Cause additions by cutting it.
Actually, what madam has clearly told, she will do a hysteroscopy again, but she will not cut it if it is very small. I think that is one thing.
And there are lots of studies coming in. I mean, there is a study which says that there is a upper muscular and the fibrous part. The fibrous part definitely should be cut. But if it's a very muscular part, you have to think twice before you cut it.
And that is one criteria to stop cutting also. If
Absolutely.
it is vascular, you can stop cutting.
You stop cutting.
So, like already mentioned, we just conclude on this point. Hysteroscopy is very good in identifying the intrauterine pathologies, which may not be detectable in ultrasound as well, the polyps, endometritis, small septum, and so on. So, the polyps, myomas, adenomyosis, hydrosalpinx, anyway, I don't think there is no need of any discussion because it is not at all controversial.
Small polyps, now, like there were a lot of people were talking about these small polyps, see less than sub-centimeter polyps, 0.5 point. Is there a situation that we don't do remove it and transfer?
No, that if you remove also, it will come back because that is due to endometrial preparations. So basically, you just leave her alone for some time. That will just.
Yeah, so probably might not do a transfer that cycle. See if it is getting withdrawal in the next cycle. If it is still retaining, then we do a polyp is again a polypectomy in these smaller.
I think a natural cycle may be better for
So we'll ask Jisha. So like Parshu told, it is not sub-centimeter, it is 1.2 centimeter endometrial polyp. You did a hysteroscopy, removed, and the next cycle you are preparing the endometrium. By when the patient came on day 2, the polyp is not there. Then patient is on day 9, again the polyp is there. What will be your next step?
What is the size of the polyps, sir? Next
1.2.
Next time, earlier it was 1.2. Now it is 1.3.
1.3 centimeter. Definitely, I will counsel the patient that again polyp has recurred. But one thing I will do, sir, like if once she had a polyp, next time I will prefer to do a natural cycle FET and or a downregulated FET with a low dose estrogen.
So
Maybe
can you just tell us in brief what you mean by natural cycle FET in your practice?
Natural cycle FET, sir, if the patient is ovulating, it's an ovulating patient, we will be doing her, we will be calling her on day 2 to do the baseline scan. We will do I personally do the hormones as well, the progesterone and estradiol also. And then we call her maybe around day 9 to see the endometrial thickness and the follicular growth. And if the follicle is around more than 14 millimeter and the endometrial thickness is around 8 millimeter with a trilaminar pattern, I will be starting giving her progesterone and transfer accordingly. Or if I or I will do an HCG trigger and then plan the transfer accordingly, sir.
Yeah,
or
HCG trigger is modified.
Modified.
Yeah, modified, sir. If she's not ovulating, I will give her some letrozole or low dose GH.
Okay.
And then we'll do.
Then this hydrosalpinx, is there any reason to do excision of the hydrosalpinx rather than delinking? What is your practice, Jisha?
That depends upon the access to the hydrosalpinx as well, sir. Sometimes there will be a lot of adhesion, so how much ever like it is convenient during the surgery, I will be doing. If it like there is no problem with the access, I will be cutting it and going for the transfer, sir.
So do anybody prefer excision of hydrosalpinx in all cases or only delinking in all cases? Madhu?
It depends on the situation, as you said. Most of the cases, if the ovary is very close to it, as in usually when there is pelvic infection, the ovary may be close, and then you would prefer a delinking, unless it's just a, if it's very easy to remove, fine. And another thing is when you remove it, you can, if there is a hydrosalpinx and you're only doing a delinking, you have to keep the thing open also, because in case she has pain.
Percy, you want to add something before going to?
No, that's what. See, for example, as a policy that we always do is we only do a delinking, because the whole idea is for the fluid to not prevent from coming into the uterus. And if it is a very large hydrocephalus, we will always prefer not to do a self-injectomy, but because we should always keep a note that there is be a located collection that is happening there, which will look every time when you're doing a scan, or every time one can, if there is a doubt of ectopic, if there is so many, so you should always keep in mind that there is something like that there. A lot of times we might even just a linear incision and make sure drain the fluid, but what happens is that again will fuse, again there'll be collection there. So it is only a temporary scenario. Again, removing the what is hydrosalpinx, we preferably don't want to remove it, because we feel that if at all again she requires another stimulation, probably that can affect their ovarian reserve, because whatever said and done, most of these patients' tubes and ovarian blood supply are interconnected. So we always preferably only want to do a delinking in most of the situations.
Dr. Rudri, you want to convey something?
Yes, sir. Sir, we are just left with 5 more minutes. So just requesting to conclude, please.
Yeah. So before that, we'll just take an opinion from everyone. What is the thinnest thickness of the endometrium you have done transfer in your situation, in your clinic?
And got pregnancies.
Yeah, you got pregnancies, thinnest endometrium.
4 millimeter.
Thickness. Lowest thickness in which you got pregnancy.
6.5.
6.5.
That is because of repeatedly. There's nothing else to do. Hysteroscopy was done.
6.5. Parasu?
6.1.
I think probably 5.5, something like that. 5.5.
Oh.
Then 4 millimeter. Rather good at no endometrium.
That's a good endometrium, vascularity.
Yeah,
and
that's the thing is, that's what, when we talk about endometrium, whether we look at just an endometrium or 3-line pattern sometimes I feel is a more significant, very significant factor than actually the thickness. Yes. The pattern is very good.
Even a secretary endometrium will be thick. For the sake of thickness, that will be secretary, but the triple line is the most significant, and the blood flow.
There is a beautiful paper on this, where is the pregnancy rates were considered 4 millimeter onwards.
Yeah,
and there have been significant number of pregnancies. Even 4 millimeter onwards, there was a nice paper. Forgotten.
Yeah, in your practice,
this is by Atta et al. Actually, what they have told is that euploid embryos, if you transfer, the endometrial thickness may not matter. We can go transfer up to 4 millimeter as said, and
I got pregnancies at 4 millimeter also.
No, Mahesh, your experience 4 millimeter?
Yes, 4 millimeter.
Jisha 4 millimeter?
No, sir, 6.5.
6.5. So Mahesh lowest caught. Then anybody else?
Now another question to the panelist, because it's a part of the thickness we are talking about. Now, how many of you, for example, for a frozen embryo transfer, especially now when you're doing a frozen embryo transfer in patients with failures, anyone of you look at actually the endometrial blood flow? For example, thickness is already above 8 millimeter, 9 millimeter, but do you look at the endometrial blood flow before deciding on starting progesterone? What is your take on it?
In RIF, yes.
Not RIF, in general, otherwise.
In general, not much.
In general, I look at it and I record it. I may not use it all the time, but 3 and 4 usually. I do record it.
The first is morphology, how beautiful it is.
Morphology, definitely.
Second, only the brain comes.
Because why I was coming out is because we had done multiple studies, all the Applebaum criteria, everything we looked at. And probably the only one parameter which we felt was significant was actually blood flow, where we waited. For example, then we did a study saying looking good endometrium, but without blood flow, and looking good endometrium with blood flow. And actually the blood flow once had a little higher pregnancy rate. So since then, but again, looking at the blood flow is again looking at the power Doppler and seeing the blood flow. Your machine has to be good. The settings have to be done correctly. The position of the uterus has to fall in properly. If it is a standing uterus where it is not neither anteverted or retroverted, sometimes you might not really read the blood flow. So all those things needs to be looked at. And so when you start progesterone, we generally always wait for all the blood flow to reach up to a zone 3 and then only think of transfer. That is our own experience.
So some cases we may not get a trilaminar pattern only, no. So some cases, in those cases, we have to rely only on the vascularity, right?
Which one?
So some cases we may not get a trilaminar pattern itself.
That is actually very bad. I don't know, without trilaminar pattern.
Morphology is first.
First is the morphology.
Parsu, do you transfer in focal zone 3 or full zone 3?
No, focal zone 3, because again we'll have another 3 more days. No, once we start progesterone, we'll have another 3 or 4 more days. And actually, what is interesting is it's not that it is zone 3, zone 2. You're seeing it's going to be continuously zone. Actually, just wait for 2 days. It will come up, and in 90% of the situation, the perfusion will increase in 2 days.
Yeah, one issue in waiting beyond some time, maybe 14 days or something, it may turn to secretory also.
Yes.
Yeah,
It can.
that possibility is always there. That possibility is always there. But what I've seen is in most of the situations, it is okay.
And see, in this particular patient, we can change the stimulation to PPOS. We can have dual trigger, something like that. And PGTA also can be recommended in this patient. And transfer methods, we have a lot to discuss, progesterone support. Anyway, with as the time is running up, thank you all the panelists. We didn't take it up to a great extent, but in fact, it was a very good discussion with regard to the definition. And as per the inputs from all the panelists and the experts and everyone, I think it is high time that we should have an Indian definition soon. Thank you. Thank you, Dr. for supporting.
Thank you, and Parishu. Thank you.
Thank you, everybody.
Thank you all. It was nice discussion.
Nice. Thank you. So to end today's session, thank you so much, Dr. Kunju Mohiddin sir and Dr. Parshu, for taking this, such an important topic for all the IVF specialists out here, at understanding the RIF. And we have got so many definitions, and we have got so many newer technologies coming, and it's always confusing what to use when and what all to offer, because sometimes it also depends upon, where you are practicing, your tier 1 city, your tier 2 city, tier 3 city, and what all we can offer it to the patients. So having all the ideas about, whatever the technology is coming in and what we can use for it is such an important lesson to be learned. And I think this is one topic that whenever we discuss, and so many times we discuss and we read about it, we go through conferences, but every time we learn some or the other thing which is new. Like last time in the S-ray, we learned everything about, microbiome, the PRP and everything. So yes, so I think it is the way that we take the patient, individualize it, and use each and every technology which is available to counsel the patient and to take it further. So yes, I think panel discussions are the best way to learn anything that we know and to put it and implement it practically with gathering all the points from everyone around. So thank you again to all the panelists for taking out time in the busy evening after your OPD or in between the OPD. And it was such a fantastic session that we had. Thank you, UNS, for hosting this webinar. And thank you, Archana Basay, for being the program director and having all these webinars every once in a month. And we will be looking forward for the next webinar as well. Over to UNS, if Dr. Manish would like to add in something.
Yeah, ma'am. Thanks a lot for giving UNS opportunity to collaborate with you and the team for this second webinar in the series. Again, a warm thank you, and it's a pleasure and privilege to host all the leading experts in this field in this webinar. So a sincere thanks and thank you for all your support for this webinar. And we look forward for such future scientific collaborations. Again, thanks a lot, and signing off, wishing you a happy evening and a good night, sir.
Can I just take a minute? I think Dr. Madhu and Dr. AB, if you can, and Rudri, if you can just switch on your camera, I'll just take a quick picture when everyone can smile. Dr. Rudri, Dr. AB, if you're here, Dr. Madhu.
Ma'am, I'm just traveling somewhere, so I'm excuse me.
Dr. Madhu? I think
ma'am,
yeah, I can do that. I can do that.
Yeah,
One second.
One quick, just for
one
memory.
second. I'm on the mobile, so I'm just trying to take one.
Yeah.
Just a sec.
Everyone can smile.
Yeah. I also request Dr. Archana Basir ma'am to concluding
I think
remarks.
ma'am is left for the evening. Thank you so much for the wonderful picture. Thank you. Hope to see you all soon again. Thank you. Thank you, sir. Thank you. Bye. Good night.
Thank you, ma'am. Thank you. Good night, ma'am.
Recording stopped.